Hi, everyone. Thank you for joining us for our next segment in Getting Pediatric Ready. I am joined here with Dr. Owusu-Ansah, our pediatric expert physician and Chief Pinchalk of Pittsburgh EMS, who are going to help us provide guidance on this particular section when we're asking, are we pediatric ready at our agency level? So the first section on education and competencies for providers, let's go through this section. And what I'm hoping to do is I want to get some explanation or examples of how can we meet these goals. So the first section of this checklist is about processes for ongoing pediatric specific education using one or more of the following modalities: classroom or in-person didactic sessions, distributive education, skill stations with practice using pediatric equipment, medication and protocols, or simulated events. From my understanding, this simply means that we are providing educational opportunities around the care of pediatric patients within our agency. Am I understanding that correctly?
Yes, I would say that is the case. I would say not only providing opportunities, but consistent and frequent opportunities for pediatric emergency care or pediatric care. Because as we know that, in EMS, pediatric calls make about anywhere from 5 to 13% of the calls, so a small percentage of the calls. So we don't see pediatric patients as much as adult patients, but it's even more important to keep up with the nuances of pediatric emergency care in our EMS systems by providing not only education, but frequent and consistent education related to this specific population.
Yeah, that's what I like about this guideline is gives you some good ideas what you could do in your system. So we, like everyone else, we do pediatric advanced life support every other year. We just wrapped up a cycle with this, but this gives you a lot of good tools. We can go with called multimodal and get people to do some hands-on. So we're thinking pediatrics more than one class every 2 years. So, we do kind of some distributive models. We'll bring crews into our training division, or we'll go out to the field and do little mini blocks. But I like this saying, like, hey, we could do a 10-minute thing on basic airway management one day. Another day we can come back and review the pediatric assessment triangle. So I think there's some good tools in here to really give you some good ideas to kind of do little things to needle this problem all the time and keep people thinking about pediatric care.
And I like this idea that we're not just talking about, do I assign a pediatric module online at a certain frequency, right? That I'm thinking about how do I give people exposure, whether or not it's knowledge, but also the ability to practice some of these skills that they may be less comfortable with because they're infrequent. So I think the task for myself as like a agency medical director and agency leader would be go back and like look at our training schedule, right? And the topics that we've done, the training schedule, both in distributive or live, and say, how frequently are we actually doing, right, pediatric education? Is it really once a year or once every other year? When was the last time we did that? Or whether or not we are providing sort of the ability to do spaced repetition around pediatric education, as I think seems like what the goal is, and that's how I would go about and assess it.
I would agree with all that. I mean, I think it's just keep doing it all the time. It's not, okay, we did it this month and we'll talk about it again next year. And just different topics, like one month or one quarter could be airway management. You come back the next quarter's IO access using Broselow tape and given the right amount of fluid and drugs. So I think it's a good opportunity to just constantly address different issues in these kind of low frequency resuscitation events.
It's also good for EMS agencies to know there's numerous resources in the way of providing pediatric education or pediatric care education or pediatric emergency care education, excuse me, especially geared towards EMS agencies. So of course, many of us know PALS, Pediatric Advanced Life Support, through American Heart Association, but there are also other education modalities such as the Pediatric Education for Prehospital Providers, otherwise known as PEP. There is the Emergency Pediatric Care through the National Association of EMTs that have pre-described PowerPoints and slides for didactics that are good for in-person and online didactics. Prodigy also has a 14-module pediatric emergency care module just recently released, led by Dr. Tabitha Chang, that relates to pediatric emergency care in these spaces. So it's also good for EMS agencies to know that there are a myriad of resources to get pediatric emergency care education from.
The second part of this sort of goes beyond the process of just, do we have the education available? And it's asking a bit further. It's saying, is there a process for evaluating pediatric specific competencies for the following types of skills? And it lists a series of psychomotor, cognitive, and behavioral skills specifically around the care of pediatric patients. Can you describe a bit about what is meant by each of these categories and give an example of how an agency can assess whether or not they're doing this? Should they be able to check off all the skills in every single category and have a process, or are you hoping that they just have something in each category, but not necessarily everything? What are your thoughts on that?
So I think ideally, we would want to, years down the line, get to the point where all of our agencies are clicking off all of the boxes. But again, this is just a reminder that this checklist is to look at where we are currently. So it is okay to say that maybe we are focusing on airway management and medication administration, but not so much fluid therapy. But this checklist would then be a reminder that, if that is not the case, maybe we should start looking into that for pediatric patients. In the means of examples, I'll just start with, I'll use airway management for all of the three subsets here. In this airway management example, I'll use bag valve masking. And Chief Pinchalk could speak to this. We this year created an airway station where the focus was, hey, do we have the equipment? So one, you want to make sure you have the right sized equipment for your pediatric patients, the right size face mask. Again, we're talking about bag valve mask ventilation as this example. And so, for instance, for psychomotor skills, you want to be able to bag valve mask a child and make sure that there are no air leaks, make sure that you give enough pressure just to see the chest rise up and down. If it's a 5-year-old, for example, you want to make sure that you're breathing at a rate of 20 to 30 breaths per minute. So you want to know that your EMS clinicians have these pediatric specific skills that may not trickle over to, adult patients that are pediatric specific. And looking at cognitive skills and kind of still talking about the airway management, you want to be able to know the developmental differences in pediatric patients versus adult patients. And anatomical and physiological differences. So if we go back to the airway again, and let's say we are bag valve masking and we need to place an airway, it's good to know that children have more anterior airways. And so if you were to have to do an intubation, you would want to look more anteriorly. You also want to know that they have shorter necks and bigger heads. All of those things would help you to provide better airway management in a pediatric patient. And when we get to behavioral skills, we have to remember that unlike adults, pediatric patients come with family members and caregivers, and it's a holistic package of caregiving as opposed to the one-on-one taking care of the adult provider that can consent. We are taking care of minors that are unable to consent a lot of times for their care. And so we need the parents to be around. Parents or caregivers are a wealth of resources in the way of the medical history of the patient, in the way of the acute illness of the patient. And so, let's say that we are having a pediatric patient that is having trouble. We're having trouble managing the airway. It is very important that we let the parents know what is happening and how we are trying to improve, their patient's illness and what is going on. It is, I'll give another example. We're currently in the season of Ramadan. The season of fasting for many Muslims throughout the globe. And so in talking about behavioral skills, but not limited to cultural awareness, an example in the midst of Ramadan is, these families who celebrate Ramadan fast during the day, and then they feast at night. And so there may be certain situations, let's say a pediatric patient may require IV fluids, that you're concerned that they're in shock. But because of the practices around Ramadan, they may or may not be able to receive fluids because that may be considered breaking fast. Now, in the sense of Ramadan, you can give fluids. It wouldn't be considered breaking fast, but it would be good to know that that would be a discussion that you would need to have around that. So hopefully those analogies were helpful in looking at psychomotor, cognitive, and behavioral skills that are pediatric specific.
Yeah, one comment out on that too is looking at those three domains, they're all very valuable. I think the important thing is be able to combine them and use them with good decision making. So airway management's a skill, patient assessment, the pediatric assessment triangle is a skill, but it's important to be able to realize, put these all together, make a good clinical impression of what's wrong with your patient and when to apply them. So one of the biggest things we emphasize in what we call our crashing patient doctrine, which is a critical care doctrine, is aggressively managing respiratory failure. And respiratory failure can be subtle sometimes. So there's not one set number, like if the CO2 is this or the SAT is this, they're definitely in respiratory failure. So we really push, like on the assessment, hey, if they're altered, if they're only a P or U and an AFPU, you need to do something with the airway. We need to position, suction, look at an adjunct, and then have a low threshold to go to positive pressure ventilation. And just doing stuff like that is going to keep your patient alive in the first 10 minutes. So I think these are all very valuable components, and the good thing is to combine them into good decision making.
So I'm going to provide a little bit of a summary on the education portion of the checklist. So if I'm an agency who's participating in this, what I really want to do is it's worthwhile going back and looking at my training schedule, at people's research education, and saying, what have we covered? What is the frequency with which we covered? And is there a way that we can modify that to better meet those needs? And then I can specifically look at some of these key elements of key psychomotor skills, cognitive skills, and behavioral skills, some of which are pediatric specific, and some of which are not necessarily pediatric specific. But thinking about, have I really touched on these elements? And if I'm not really doing much pediatric education, can I use those as a starting point for thinking about sort of longitudinal spaced repetition curriculum at my agency? And sometimes the first point is I might be doing a checklist and realize, wow, we're not meeting this. But the goal is that I use that to think about, right, what changes can I make to improve the care that we're providing to children? So thank you for all those wonderful examples. And we will be back to talk about equipment and supplies.